Afternoon, everyone. It's a minute after noon, so we'll get started. I'm Dr. Julie. I'm the Deputy Chief Medical Health Officer for the province. So today's rounds includes a presentation from myself and also from Dr. Alex Wong. So thanks everyone for being here, and for folks on the line. I think people on the line need to mute their phones because we're hearing some background here. So before getting started, I just wish to acknowledge that we're on Treaty 4 territory, the original lands of the Cree, Ojibwe, Saulteaux Dakota, Nakota, Lakota, and the homeland of the Métis Nation. I will be talking about our province, Saskatchewan, so I also wish to acknowledge that the name of our province comes from the Saskatchewan River, named by the Cree as Kisikatchawani Sipi, which means the swiftly flowing river. So this presentation is in anticipation of World AIDS Day, but it's also about the week before and the week after World AIDS Day, which is on December 1st. So I'm going to provide you some background about World AIDS Day. I'd also want to place HIV in the context of sexually transmitted and blood-borne infections in Saskatchewan. I'll then talk about the progress on the Saskatchewan HIV Collaborative Work Plan. And hot off the press are Canadians' new information on Canadians' awareness, knowledge, and attitudes about STBBIs, which was public opinion research and will inform our work moving forward. So as I hope all of you know, December 1st is World AIDS Day. This is an opportunity for people worldwide to unite in the fight against HIV, to show support for people living with HIV, and to commemorate those who have died from an AIDS-related illness. Importantly, the theme for this year's World AIDS Day is Know Your Status, which has particular significance to our province and the populations that are most disproportionately affected by HIV. World AIDS Day was founded in 1988, and just a piece of trivia, it was actually the first ever global health day that was declared. And then the other question is why the red ribbon? We're all wearing a red ribbon, and you can see the red ribbon on this poster. This symbol was created by the New York-based Virtual AIDS Artists Caucus that wished to create a visual symbol to demonstrate compassion for people living with AIDS and their caregivers. Inspired by the yellow ribbons honoring American soldiers serving in the Gulf War, the color red was chosen for its connection to blood and the idea of passion, not only anger, but love, like a Valentine. First won publicly by Jeremy Irons at the 1991 Tony Awards, the ribbon soon became renowned as an international symbol of AIDS awareness. And for those of you who are old enough and remember HIV and AIDS in the 80s and 90s, we all lost friends and colleagues who died of this illness. A number of events are planned for the week leading up to December 1st. There's AIDS Awareness Week this week, and in the week following, Aboriginal AIDS Awareness Week. And Dr. Khan, who's with us today in the auditorium, will be presenting on December 3rd to celebrate Aboriginal AIDS Awareness Week. You can find a list of events on the Saskatchewan HIV Collaborative website. So please, if you're not familiar with this site, please go there. There's lots of information not only on the events, but a number of tools and resources. So I want to shift to talk about sexually transmitted and blood-borne infections. Clearly, HIV and hepatitis C are included in that. The graphs and maps on this slide and the next one are extracted from a summary of STBBIs that was prepared as part of a health system analysis. There has been quite a concern across Canada around rising rates of STBBIs, and there is, in fact, a pan-Canadian action plan to address STBBIs. So in Saskatchewan, we're beginning to look at what further we need to do. I have a number of copies of a handout that was shared with senior leadership in the ministry and Saskatchewan Health Authority. It looks like this. It's like a placemat size, and there's some text on the back. There's some extra copies on the table there if you want to go home with that and look at it. This handout will also be made available electronically. So the graphs on this slide show the trends in HIV and hepatitis C in Saskatchewan, which is the red line, and Canada, which is the gray line. Please be aware that the scale of the y-axes for these two graphs are different, so you can't compare the slopes of the two trend lines. However, you can see that the Saskatchewan rates of persons newly diagnosed with HIV and hepatitis C have remained consistently higher than the national rates from 2008 to 2016. National rates are not available for 2017. In Saskatchewan in 2017, there were 177 persons newly diagnosed with HIV and 713 persons newly diagnosed with hepatitis C. So hepatitis C is an indicator disease that these people are, not only have they acquired hepatitis C, but they're also often at risk of getting HIV. In 2017, the male to female ratio of HIV cases was approximately 2 to 1. What is important in terms of the epidemiology is that 85% of the female cases were in their childbearing years, and this represents a risk of maternal fetal transmission. In 2017, the male to female ratio of hepatitis C cases was approximately 3 to 2. The maps of Saskatchewan show the former health authorities with HIV and hepatitis C rates that were higher than Saskatchewan's rates overall in 2017. And you can see that the former Northern Health Authorities in Prince Albert Parkland have higher rates. So that's the darker color on this map. Depending on the disease, there are also other former health regions that have higher rates than the Saskatchewan rate overall. So although the primary risk factor for HIV and hepatitis C transmission in Saskatchewan is intravenous drug use, sexual transmission of HIV should not be forgotten. It's important to realize that more people have sex in this province than use intravenous drugs. In 2017, 20% of the HIV cases reported heterosexual exposure as their primary risk factor, and 8% were men having sex with men. Furthermore, 45% of the HIV cases reported 3 or more risk factors. So risky behavior comes together in terms of people will have more than one risk factor. But what we record is the primary risk factor as the risk factor that was most likely to have related to transmission. These three graphs show trends for chlamydia, gonorrhea, and infectious syphilis from 2008 to 2016. Again, the scales of the y-axes for the three graphs are different, so you can't compare the slopes of the three trend lines. However, you can see that Saskatchewan's rates in red, again, of chlamydia and gonococcal infections have trended consistently higher than the national rates. You can also see that there has been a notable increase in the rates of gonococcal infections and infectious syphilis from 2015 to 2017. In 2017, 8% of the cases of infectious syphilis were females. Preliminary data for 2018 indicates that 30% were females and that 95% of these females are in their childbearing years. And again, this has enormous consequences in terms of maternal fetal transmission and having congenital syphilis once again in Saskatchewan, which has not been present for decades. On the maps, you can see that the former Northern Health Authorities, Prairie North and Prince Albert Parkland, have higher rates of chlamydia and gonorrhea than the province overall in 2017. And the highest proportion of infectious syphilis was reported from the former Regina and Saskatoon health authorities. And this is primarily because of outbreaks amongst men who have sex with men. So what can be done to address these STBBIs? And Saskatchewan is not, as I said, is not alone. Across the country, the rates of STBBIs have been increasing. HIV and hepatitis C infections are most often asymptomatic, as are chlamydia and gonococcal infections. Symptoms of infectious syphilis, when left untreated, are mild and disappear. However, these infections have impacts on health if left untreated, and all of these infections are preventable and treatable. Addressing the health challenge, it requires attention in 4 areas. The first is to address the gaps, for example, reducing barriers to accessing patient-centered care, especially in rural and remote communities and for high-risk populations. The second area is in the area of prevention, to promote healthy sexual decisions and promoting harm reduction initiatives. Because the vast majority of these infections are asymptomatic, it's really important that we test to find infections. We need to test in the clinic, on the street, in the shelters, or by peers, and really expand our reach for testing. Patients maybe are unaware that they may be infected, and the only way to distinguish that, to find that out, or to diagnose these diseases is, in fact, to test. We also need to treat early to break transmission of infection, to improve health outcomes of the individual, and to reduce the costly long-term sequelae. And all of these diseases have long-term sequelae, which I'm sure that you're all familiar with HIV being the most serious, where most people, if left untreated, will die. So I'm now going to shift to the Saskatchewan HIV Collaborative Work Plan. This is a work plan that was developed for 2017 to 2020. It was based on the International Association of Providers of AIDS Care Guidelines for optimizing the HIV care continuum for adults and adolescents. And you'll see that Goal 2, 3, and 4 are aligned with the UNAIDS 90-90-90 targets for 2020. So there are 5 goals: optimizing the HIV care environment, increasing HIV testing coverage and linkage to care, increasing HIV treatment coverage, increasing retention in care, treatment adherence, and viral suppression. And the last goal is to measure how we are doing by improving HIV surveillance, program monitoring, and evaluation. So in the next 3 slides, I'm going to map the framework that I had presented in terms of what can be done to this HIV collaborative work plan. It's important to realize that these are, it's just different ways of looking at a problem. And you'll see that it doesn't matter which way you look at the problem, that we are categorizing our work. We can categorize our work in each of these frameworks. So interventions aimed at optimizing the HIV care environment may address gaps or improve prevention, testing, or treatment, and often impact in more than one area. This next slide shows the relationship of the goals 2, 3, and 4 of the HIV Collaborative Work Plan to what can be done, which is primarily related to test and treat. And the 90-90-90 indicators are generated from data about HIV testing, HIV medication prescriptions, viral suppression that's generated by patients accessing care. And then finally, you can see that surveillance, program monitoring, and evaluation has to cover all the areas in terms of what can be done. And the 90-90-90 indicators are there as well. So I'm just going to share with you some of the highlights in terms of the successes that we've had over the last little while in terms of implementing the Saskatchewan HIV Collaborative Work Plan. And the first area is around addressing gaps and optimizing the HIV care environment. I think one of the most important initiatives is building the primary care capacity through workshops and virtual classrooms. In 2018, there was a workshop, and planning is underway for a second workshop in March 2019. 2 virtual classrooms have been delivered. And in addition, there is a collaboration with BC Centre for Excellence in HIV and AIDS to offer preceptorships to 3 persons that will receive scholarship to attend these, because these are done in Vancouver. Work is also underway to build primary care capacity using this kind of model for diagnosing and treating hepatitis C. A lot of this work has actually been funded by the Public Health Agency of Canada, and we are incredibly grateful to the input of funding from the federal government on a number of these initiatives. The second area in terms of optimizing the HIV care environment relates to the federal, provincial, territorial work on decriminalization. And I've been personally involved in some of this work because of the tables that I sit at in the Pan-Canadian Public Health Network. So the Public Health Agency of Canada, in collaboration with provinces and territories, conducted a synthesis of the scientific evidence of risk of HIV transmission during sex. And this was an input to the Federal Department of Justice's document, Criminal Justice's Response to Non-Disclosure of HIV. This document was released a year ago in December 2017 and received some media attention because it was released intentionally around World AIDS Day. The synthesis of the scientific evidence of risk of HIV transmission during sex was recently published in the November 19th issue of the Canadian Medical Association Journal. It's the same information, it's just been put in different, it's gone through another peer review process. I think it's important to realize that the federal document of Criminal Justice's Response to Non-Disclosure of HIV is a guidance document that provinces can use to review their respective prosecutorial processes. The prosecutorial processes in each province determine whether a person living with HIV may be prosecuted for sexual assault under the criminal code. Please take note, there have been no changes to the criminal code, and in the current Canadian context, there may still be a legal risk of criminal charges being laid for non-disclosure of HIV. I'm continuing to work with our Justice Department in terms of looking at our prosecutorial guidance. There's also been an HIV social marketing campaign, Talk, Test, Support. There are washroom posters and a YouTube video, online and radio ads, and you can see this video on the Saskatchewan government website. I've been given the 5 minutes, so I'm going to speed up. Another area in terms of optimizing the HIV care environment has been the incredible work through Know Your Status that has increased community engagement, and Dr. Khan will be providing you more information about that next week. There has also been significant work in improving peer engagement, and based on input from peer focus groups, we now have a Living with HIV section on the HIV Collaborative website. There have been 2 peer knowledge exchange events held in 2018, and peer training module is under development. In order to address gaps for surveillance and program monitoring, we recognize that more information is required sooner. So the HIV Prevention and Control Report for 2017 was released in July of this year rather than waiting till World AIDS Day. The Harm Reduction Report for 2016-17 is also available on the government website, as is the 90-90-90 indicators for 2016. Another accomplishment is the First Nations 90-90 indicators for 2016, and these were published by the federal government in July of 2018. For preventing HIV, pre-exposure prophylaxis guidelines were made available on the Saskatchewan HIV Collaborative website in January 2018 this year, and to date there have been 16 PrEP clinics have been held in Regina and Saskatoon. Pre-exposure prophylaxis is now funded, completely funded, and this also relates to funding for treatment. The infant formula program continues to be a very important program to provide infants with infant formula for infants who have been born to women living with HIV. So in 2017-18, 27 infants benefited from this program, and another 23 infants have benefited to date. Although not mentioned on this slide, I think it's important to note that 41 pregnant women living with HIV delivered infants in 2017, and there have been no confirmed HIV-infected infants reported so far, although it may take up to 18 months to confirm this. Each of these deliveries requires enormous coordination and care in the acute care sector, because many of these women have multiple risk factors for obstetrical risk factors, not just about their HIV transmission. Finally, and most importantly, well, not most importantly, a very important pillar is our harm reduction programs. And there has been expansion of those programs. So there are now 26 fixed and 3 mobile sites. And in addition, there are now 30 harm reduction sites operated by Indigenous partners. A big announcement most recently is that in the next few months, harm reduction programs will be able to offer inhalation supplies to their clients for safer use of crack and crystal meth. So for those people who are using these drugs intravenously, this is reducing their risk by having oral kits available. One of the activities in on the public health side has been a public health HIV case review. So persons who are newly diagnosed with HIV are reported to public health, and public health follows up with their contacts to see if they have HIV and other sexually transmitted infections. After patients are followed up initially by public health and linked to care, public health may not actually follow them anymore. And so what we've instituted is a systematic review of all cases, HIV cases living in an area, to see if their viral load is suppressed. And if their viral load is not suppressed, then public health will once again follow up with those individuals and redo the contact investigation and provide education to those contacts in efforts to prevent transmission of HIV and other STBBIs. In terms of testing, as you can see from this graph on the red bars, we continue to increase the number of HIV tests performed in this province. These tests are done by the provincial laboratory. I want you to take note of the black line. That line indicates the number of positive HIV tests per 1,000 tests performed. This black line has always been above 1.5 positive HIV tests per 1,000 tests performed. And we know that if the prevalence of undiagnosed HIV infection is greater than 0.1%, HIV screening is as cost-effective as other established screening programs for chronic diseases. So one positive HIV per 1,000 tests translates into a prevalence of 0.1%. I know that there has been some pushback from some physicians about the appropriateness of our HIV testing policy. It's important to remind them, or you, if you are a healthcare provider, that the HIV testing policy is not the cost of the HIV test itself, which by nearly all standards is inexpensive, but rather the downstream future costs of HIV care for patients who are identified and then treated for their HIV infection. So we do wish to continue to promote testing as a routine policy. The activities in Saskatchewan relating to testing have been recognized nationally. So the Canadian AIDS Society declared June 27th, 2018, the first National HIV Testing Day in Canada. And this was in recognition of Saskatchewan. They recognized Saskatchewan's efforts in 2017, which came from community-based organizations and a grassroots initiative to do a testing day. And the Minister of Health has now proclaimed June 27th as a provincial testing day, which is great. We are, in fact, leading the country in terms of this. These data show the impact of the testing day on testing. So if you look at the testing results in Q2 in 2017 and 18, Q2 includes June, so it coincides with the establishing of the HIV testing day in Saskatchewan, and you can see that the number of tests bumped up in those quarters. So far, based on the number of HIV tests performed at the provincial lab in the first 3 quarters of 2018, we anticipate there will be a 5 to 6% increase in the total number of tests performed in 2018 as compared to 2017. As far as testing, we have increased the number of point-of-care test sites. There has been work in rural and remote communities, First Nations communities in particular, to implement dry blood spot testing, which is an acceptable form of testing. This test result is these tests are processed at the National Microbiology Lab in Winnipeg. There has also been efforts to do routine HIV testing on an inpatient basis or in emergency departments, so in acute care facilities, and these initiatives need to continue. In terms of treatment, as I mentioned, there's been full coverage of HIV medication. This was effective April 11th, 2018. So all persons in Saskatchewan get their medication 100% covered. This was an enormous kudo, I think, in terms of having this funded. There are clinical management tools that have been prepared and are available on the HIV Collaborative website. And I've mentioned the capacity building of primary care clinicians. Mike Stuber has also been doing capacity building of pharmacists, which has also been very important. I've already mentioned the Public Health HIV Case Review. The reason I'm putting this here is that the Public Health HIV Case Review supports the efforts of clinicians to re-engage persons living with HIV in care and treatment. So there really is a dance that public health and acute care need to play in terms of the following persons living with HIV through their lives to support them in being adherent with their medication. Finally, I'll end on the UNAIDS 1990 targets. The first 3 bars are at 100%, and this reflects the number of persons living with HIV diagnosed and undiagnosed, which is used for the denominator of the first 90, as shown in the next 3 bars. The Public Health Agency of Canada estimates the number of persons living with HIV diagnosed and undiagnosed using mathematical modeling. I want to just caution you that these indicators should be interpreted with some skepticism, as data completeness, data sources, methods, and definitions differ from province to province as well as from country to country. These indicators are only a starting point to monitor our progress, recognizing that the data and methods used to calculate the indicators will be refined and improved in the future. Within the province, we are looking at indicators that will allow us to compare from year to year in a more reliable way. And when those are ready, we'll be sharing those with you. What we can infer from these indicators is that there's clearly room for improvement. In Saskatchewan, we know that persons are not adequately being retained in care nor adequately adherent to medication, and this means HIV transmission will continue. In 2016, there were 1,223 persons living with HIV who were viral suppressed, of the 1,732 who are diagnosed. That means that 30% of persons who are diagnosed with HIV are not virally suppressed. We need to celebrate our successes, but our collaborative work is not done. The final slide, I just wanted to share with you, as I say, this is hot off the press. It's a public opinion research survey that was done, funded by the Public Health Agency of Canada. And I've selected a few highlights for me in terms of where some of the misinformation is and where some of the things are that we would need to look at as we move forward. So the knowledge of hepatitis C is fairly poor. 2 in 10 Canadians believe people may get hepatitis C from contaminated food or beverages. This is clearly incorrect. 4 in 10 Canadians do not believe that a person who has HIV and is on treatment can reduce the amount of virus in their body so they cannot transmit the virus to others. 50% of respondents indicated that they have never been tested for STBBIs, and residents of Saskatchewan and Manitoba are more likely to have never received STBBI testing. And this is by report, so we don't have validated whether they have actually been tested or not. And of those who have been tested, 1 in 4 respondents had testing performed in the last 5 years. 9 in 10 Canadians would be comfortable seeking information from a healthcare professional. What we don't have is what percentage of healthcare professionals are actually comfortable talking to their patients about their sexuality and their risk of sexually transmitted infections. 6 in 10 Canadians believe that asking about testing should be a responsibility that is equally shared by the individual and the healthcare provider. So again, important for the healthcare provider to initiate these conversations. I just want to thank thank all the participants who have contributed to the progress we've made in Saskatchewan and the collaborative efforts of the partner organizations and stakeholders, in particular the people living with HIV and the communities and the community-based organizations, the healthcare providers and the pharmacies and the First Nations communities, because these are the people on the ground and are working with people with lived experience on a regular basis, everyday basis. So thank you. And then there are the organizations like me in which I work, but we provide funding and policy, but it's everything's important. But I think that the people on the ground are the ones that see the challenges that people living with HIV have on a regular basis. So thank you. Sorry, Alex. Oh, it's on the desktop. Oh, the guy, John's coming back.
Oh, yeah. This one here.
Is that the one?
No.
Or is it?
I don't know. Actually. Oh, here it is. All right, so we're a little bit behind, so I think I'm going to try in the next 20 minutes just to talk a little bit about sort of clinic-level indicators and one clinic's progress, sort of an on-the-ground report of our progress over the course of the last 5 years. And so, again, my disclosures, we do a variety of different work with industry, including research and clinical trials. If you detect any commercial bias of any sort, please contact me immediately. So my name's Alex. I'm one of the infectious disease docs here in Regina. I've been here since 2011 full-time. Over the course of the next 20 minutes, I just want to talk to you a little bit about our clinic and some of the infrastructure that exists around collecting data in our clinic. Talk a little bit about the overall sort of clinical characteristics, demographics, and outcomes for the HIV-positive individuals that we look after and care for in our clinic here at this hospital, and finally talk a little bit about some of the process changes and initiatives which we believe may have played a role in positively impacting our clinical outcomes in the clinic over the course of the last 5 years. So I want to start just by talking a little bit about the clinic. I work in the clinic along with our colleagues from the physician side as well as from the multidisciplinary side. We're a tertiary level referral clinic for all individuals living in southern Saskatchewan who have any sort of infectious disease. And so obviously that includes HIV as well as viral hepatitis. And we see lots of patients with hepatitis B and hepatitis C as well. We currently have approximately 500 individuals who are HIV positive that are active and in care within our clinic, and we obviously have a very capable and skilled multidisciplinary team that includes nursing, our pharmacist Mike Stuber, social work, dietitian, a variety of community outreach partners that do extraordinarily important work for us in terms of working with our patients and our clients, and then we also have research coordinators and finally physicians. The clinic acts as a hub for various regional activity. I'll just highlight Dr. Skinner's work with respect to his Wellness Wheel initiative, which has really helped to enhance care in rural and remote and on-reserve settings, and has also allowed us to begin to understand how best to do this difficult work. So in 2014, actually in 2013, we tried to make an effort to build some form of data infrastructure because we didn't really have the ability to answer some really basic questions like how many patients are in care, how many patients are on medication, how many patients have a fully suppressed HIV viral load, how many patients have been seen in the last year, and we felt that these were really important questions that without being able to answer them in a reliable manner, we wouldn't be able to do any type of meaningful sort of quality improvement. So what we did was we created essentially a customized electronic medical record based on a commercial package which is referred to as MedAccess. It used to be its own company, but it's now owned by TELUS. And essentially it's a web-based EMR that is one of the two approved EMRs available in Saskatchewan, along with Accuro. But the reason why we chose MedAccess was because it has the ability to be customized in a lot of different ways, and it actually has a lot of neat data reporting features which allow us to pull out a lot of data that we weren't necessarily able to do with Accuro. So what we've done over the course of the last several years is created a suite of customized clinical and reporting templates to facilitate care as well as data reporting. This also allows us to pull lab investigations as well as all of the medication and antiretroviral therapy history, which allows us to more accurately sort of calculate and determine clinical outcomes, including the 90-90-90 indicators as well as our HIV cascade of care. We generate quarterly reports for the purposes of internal quality improvement discussion at our monthly meetings and to try to decide how best to move forward in terms of various clinical initiatives to improve what's happening with our patient population. So I just want to take the next few slides just to tell you a little bit about sort of what the epidemic looks like in our clinic, which I think is a reasonably accurate representation of what it looks like in southern Saskatchewan. The caveat here being that all of the patients followed by Dr. Skinner's Wellness Wheel initiative are not included in this data. So as we see in Saskatchewan, we have a generally younger cohort. We have a large proportion of individuals under the age of 45, and then so this in Canada we see basically this curve skewed towards older populations, predominantly reflecting older MSM. So again, we have a much higher proportion of women relative to men in our clinic. In most large urban clinics in Canada, you'll typically see somewhere between 80 to 90% of the HIV positive population being men, just to reflect the fact that the predominant route of transmission is amongst men who have sex with men, and that's obviously different with our cohort. So looking here, this is just a simple breakdown of age and gender. So again, what you see, blue being men and red being women, you can see that there's a much higher proportion of younger women relative to younger men, sort of in the 26 to 35, 19 to 25, and 36 to 45 age groups. And then once you sort of get past the age of 45, you see sort of the older men likely representing our MSM cohorts that exist. Okay, so in terms of ethnicity, this has actually gradually changed, and I'll show you how this has changed in over the course of the last 5 years. We still have a little over half of individuals who self-declare as being of First Nations and Indigenous heritage, and then you can see the breakdown there. About 30% declare as Caucasian, and 10% declare as ACB, which stands for African or Caribbean or Black heritage, and a small proportion declare as something else. So in terms of the primary HIV risk factor, again, injection drug use obviously predominates. We have a relatively small proportion of men who have sex with men, and heterosexual transmission is roughly similar. When we look at the HIV risk factor trend, I apologize, I didn't actually include the trend regarding ethnicity, but we actually see two very slight but similar trends. One is that when we look at all of the data, and we began collecting quarterly data in February of 2014, we see slowly that the trend in terms of risk factor has been decreasing with respect to injection drug use, and slowly being sort of represented by other risk factors. And similarly with ethnicity, in February of 2014, we started with around 56.5% being of Indigenous heritage, and that's come down to about 52% and slowly. So we've seen these slight but gradual trends from 2014 to 2018, likely reflecting a slight change in terms of our epidemiology here in the South. Again, years of HIV positivity, this is just meant to tell everyone what you already know, which is that we have a relatively young epidemic, and a large proportion have been diagnosed just in the last few years. And lastly, just to show you a little bit of some of the QI data that we can do, we recently sort of looked more carefully at our co-infected populations. And so we have approximately 55% of individuals in our cohort who are positive for hepatitis C antibody. And then we looked a little bit further at these 271 individuals to determine whether or not they were actually still viremic or not, keeping in mind the fact that direct-acting antiviral therapy became open for co-infected individuals in April of 2017. And what we found in our setting is that we still have somewhere between 75 to 80% of individuals in our clinic who are co-infected with hepatitis C and remain viremic. And so we obviously have a lot of work to do in this regard, and a large proportion of patients that still need to be treated, despite our, I think, feeling in the clinic that we've been aggressively treating our co-infected persons. We have some work to do. And I only highlight this to say that obviously we have work to do, but at the same time, being able to collect this data and being able to actually see it makes it a lot easier for us as a team to then decide how we're going to sort of tackle these types of problems in 2019 and 2020. So now I want to just kind of show you some of the quality indicator data around how our clinic has been doing. And so this is just sort of my bias, but I think that when I look at things as a clinician, when we look at things as a team, we think about sort of three main indicators of quality with respect to HIV care. So the first is our cascade of care, and I'll explain what that is very quickly in just a moment. The second is our progress towards the 90-90-90 targets as listed by the UN and WHO for 2020. And last is our rates of HIV incidence. And I think although rates of HIV incidence is not necessarily something that we look at, I think it does serve as an indicator in regards to how we're doing, and if treatment coverage and if a large proportion of our positive population is virologically suppressed, then one would believe that the viral reservoir that exists in the community would be lessened, and that would hopefully reduce our incidence rates overall, which I think is ultimately the primary goal that we're trying to achieve here, is less new cases. So the cascade of care, for those who are not aware, again, very, very quickly, is just basically like an idealized model of how patients and individuals should sort of traverse the sort of HIV clinical journey. So ultimately, you have to start by actually getting tested, and you have to be diagnosed. And once you're diagnosed, then you have to be referred, and you have to be linked into care in some sort of HIV care setting. So here in Saskatchewan, that would typically be a more tertiary setting like Westside Clinic or RUH in Saskatoon, or Access Place in PA. And then obviously there are other settings in the more rural and remote areas as well. But the reality with HIV is that, again, we have no cure. We have no definitive cure. And so HIV is still a lifelong illness. So we have to retain people in care and keep people coming back constantly, and we have to keep people on therapy. And ultimately, the end goal is a very tangible one with HIV care. It is basically getting that individual who is positive to be able to take medications well enough in order to achieve a functionally suppressed HIV viral load, so that they are then not only not progressing in terms of their own immunity and staying healthy, but also that makes it impossible for them to transmit their virus to other individuals as well, which is extremely important in the public health context. And so what we have done in our clinic is we, I believe, track our data pretty meticulously. We track appointment statuses. So something as simple as an appointment status is extremely valuable in terms of sort of looking at it as a prognostic indicator. And we differentiate between someone that makes an appointment versus somebody that no-shows to an appointment versus someone that cancels an appointment. And we haven't actually done any analysis around this yet, although we probably will be looking at something like this in 2019, but it's been shown in lots of other analyses in other clinics around North America that when you look at the ratio of no-show visits versus sort of made or completed visits, that usually serves as a very reliable indicator of chaos and loss to follow-up. And again, that's kind of that's not rocket science. If people just don't show up when 6 or 7 times in a row after they've been booked, that's probably in some way a marker of chaos, various sort of social comorbidity, and so forth. And again, that hopefully, when we look at it, will be something that we will be able to use as a tool to be able to more accurately determine the types of individuals and the specific individuals who we can target for proactive intervention. Similarly, we also try to do the best we can to track all of the antiretroviral history in our database, including for individuals that have been transferred into care, their historical antiretroviral history as well. So we capture all of that in our database so that we have all of that information in hand. And lastly, all of the lab investigations, including CD4 counts and HIV viral loads, are pulled into our electronic medical record as well, and then subsequently can be pulled out in order to generate all of this clinical data. So the sum total of all of this is that we basically have the ability, I think at a reasonably detailed level, to track our cascade and our 90-90-90 outcomes. And this has been as a result of a huge amount of work by the team over the course of the last 4 or 5 years to continually refine and improve how we capture and report this data. So again, just quickly sort of summarize, because we're running a little low on time. The cascade of care, again, talks about sort of linkage to care, retention, whether or not someone is on antiretroviral therapy, and then whether or not they've achieved virologic suppression. But the definitions for these various cascade indicators often varies widely. And so the one thing that I would probably sort of caution, again, as Denise did in the to everybody listening in WebEx land and to those here is that the definitions play a major role in determining sort of what the numbers are. And the looser the definitions are, the more likely you're probably going to overestimate your clinical outcomes, right? So we've tried to create definitions, and these are actually the same definitions that we agreed to at a provincial level in terms of our clinical indicators when we had this discussion, I think in 2013 or 2014, around trying to come up with sort of uniform clinical indicators for all of us looking after patients living with HIV in Saskatchewan. And so I'm not going to go through those here. The one loose one is on antiretroviral therapy, which basically implies that you just basically have to have received a prescription for antiretroviral therapy in the last 12 months. Obviously, that's a very loose definition. But from my perspective as a clinician, and I think from the team perspective, the number that matters most is how many individuals are virologically suppressed. Because, unless you're an elite controller, and, there's a very, very small proportion of elite controllers, probably less than 1 in 200 to 1 in 300 individuals are actually able to control their HIV viral load without medication. If you are virologically suppressed with a viral load less than 200 functionally to allow for blips, you must be taking your therapy well enough in order to get to that point. And that is ultimately the end goal of what we're trying to achieve. So thanks to Molly Trecker, who's our research scientist that works with us in the context of public health. We pulled this data as of September 30, 2018. You can see that in terms of our retention and care, we're at 86.6%. This is 2 visits made greater than 90 days apart in the last 12 months. And this is in any setting. This doesn't have to be necessarily in the clinic. We obviously see patients in outreach settings, in correctional settings, in the rural remote settings. And then similarly, 84.2% are currently on antiretroviral therapy, and 80.1% of our individuals are virologically suppressed. And again, I'm not going to sort of contrast this with the 2014 data, but there have been dramatic improvements in each of these numbers over the course of the last 5 years. So now remember that this is just our cascade, and so you basically take the cascade and you can calculate sort of your progress towards the 90s, so to speak. Now, the first 90, again, just to remind everybody, relates to the number of individuals who are diagnosed who have HIV. And again, that's sort of a bit of a theoretical number to some degree, because we don't actually know with a great degree of accuracy how many persons actually are living with HIV in southern Saskatchewan. We can probably guess, but we like to focus on the last two numbers specifically because those are numbers that we have within our control within the clinic, i.e. the number of individuals on antiretroviral therapy and the number of individuals who are virologically suppressed based on the number of persons that we have who are retained in care. And when we look at these two numbers at a clinic level, as of September 30, 2018, on ART, we're at 84.2%, so close to the second 90, but not quite there. And then for the individuals who are on antiretroviral therapy, whether or not they've achieved suppression, we're at close to 88%. And as of the quarter previous, the summer quarter, we were actually at 89.9%. So we were close to the last 90, but not quite there. So again, what I'm going to do now is I'm just going to show you what we did was we actually pulled all of our clinical data that we have basically from December 16 onwards, and we're actually tracking sort of our progress towards the 90s. So the two that I really kind of want everyone to focus on is the red line, which reflects on antiretroviral therapy, so it's the second 90, and then the green line, which is which are these little triangles, which represents the third 90. So you can see, and then this is just kind of your relative percentages. So back in December of 2016, on antiretroviral therapy, use this red line, we were at about 73%, and the suppressed number was at about 63.4%. And over the course, there were some significant improvements over this kind of 6-month stretch, which we believe has largely to do with the fact that we were much more aggressive in terms of our multidisciplinary outreach work, in addition to our work in correctional settings, which allowed us to much more reliably engage and enhance the number of individuals on therapy, as well as being able to actually capture labs to ensure that they were virologically suppressed. And since then, we've kind of been sort of in this status quo mode to try to basically figure out how we're going to kind of get to the last, that sort of last two sort of 90s. So again, to show there are still disparities in terms of our outcomes by risk factor as well as by ethnicity. This is probably not a surprise to anyone, and so we obviously have a lot of work that still needs to be done. To show you again, Denise showed some of this data, but just looking at Saskatchewan versus Canada in terms of overall incidence rates, you can see the Saskatchewan line in the green bar versus the national incidence rates in the red. And then what I'm going to do is just superimpose in blue the RQHR incidence rates. Now, this is only to 2016 because that's where we have national data. And I mean, I should note that in 2017 and in 2018, there's been an uptick in incidence. So again, I mean, we're not by any means out of the woods, but for this 4 or 5 year period from 2012 to 2016, we saw ongoing sort of decreases within our former RQHR region with respect to HIV incidence. And so what has allowed us to actually do some things positively? I mean, I don't think anyone would argue that this is generally promising. And again, I mean, I want this to be a hopeful, optimistic talk. Like, it's not all doom and gloom. We actually have made some significant progress, and I think that has largely to do with the hard work of everybody that helps with respect to our HIV positive clientele. The one thing that I think is worthwhile mentioning is I think the medications have played a major role. Because the medications, like, again, I mean, remember in 2011, everybody that came in that was newly diagnosed, almost everybody was going on like a 3-pill once a day boosted PI regimen, which we were using extensively because the only single tablet regimen at that time was something called Atripla, and then we had a lot of circulating resistance to that particular class of medication. And so, there's nothing wrong with the boosted PI medications, but they were bigger pills, more pills, a lot more toxicity in terms of gastrointestinal toxicity, drug interactions, and so on and so forth. Now we basically have almost everybody on a small single tablet regimen or 2 small pills once a day, and they're much better tolerated with far fewer interactions than there were before. And so, there's no way to actually quantify what the impact of all of these different pieces are, but I think for me as a clinician, and I don't know, Mike's not here, but I don't know what Mike would say, but I think the fact that the medications have improved significantly have played a role in terms of the numbers getting better. And as we all know, there's new modalities being studied, including long-acting injectable medications, which will likely be approved by Health Canada for use by 2019. And hopefully every 8-week injections will be available for use by 2020. So again, I think for us, for certain types of individuals, that could really be a game changer across the board. We do a lot of work in provincial corrections. This is just the front entrance of Regina Provincial Correctional Center that we attend once or twice a month, nursing as well as physician staff. We are sort of a constant presence at Parliament Clinic, which is right in the hood, at Dewdney and Alberts, and we also tie a huge amount of our antiretroviral therapy to different forms of opioid substitution therapy, including methadone and Suboxone whenever possible, which also helps, I think, to play a role in terms of optimizing adherence for individuals living with HIV. And so some of the other things we've done, although case management is currently on hold, we've had a case management process in place basically since 2013, which again, I think has been tremendously successful in terms of helping to proactively manage some of our most difficult clientele. We have a daily inpatient review in regards to understanding patients who are admitted to hospital and ensuring that patients who are discharged from hospital have coordinated follow-up both in the community as well as in our clinic. And lastly, as mentioned, the rural and on-reserve work being done by Dr. Skinner and his Wellness Wheel team. And as mentioned before, data from their clinics is not included in this analysis, and we're hopeful that some of that data is going to be shared soon because it's probably going to look really good. So some things that we need to do, obviously, going forward in the province is optimizing the HIV care cascade, and I think there's work that needs to be done in each individual clinic, and there's different clinic level strategies, but some global strategies probably that we need to look at and implement. And again, I think one big thing, we've seen a lot of attrition in the last 3 or 4 years with respect to long-standing care staff across the province, and so really trying to support people who are on the care teams who are doing this really, really difficult work is important because burnout is real. And when we lose experienced people who really care and who know the patients, it's tremendously difficult to replace those individuals over time. And lastly, I'll just put my little plug in for data in regards to trying to continue to enhance what we're collecting across the province so that hopefully we will have more reliable sort of clinical indicators going forward, which will allow us to target our interventions accordingly. And again, I'll just acknowledge all of the strong people on our teams, including the ID Clinic Population and Public Health here in Regina, as well as our research teams, both Stu as well as myself, various collaborators and my family, and all persons living with HIV. Thank you. So unfortunately, we're kind of running out of time, and I don't actually know. I can facilitate the questions if you want, Kim. So WebEx Land, are there any questions either for Dr. Worker or myself in regards to anything presented? We'll start with people just dialing in remotely. Feel free to speak up. I can explain it in just a moment. Are there any questions in WebEx Land from anyone? We'll take that as a no. There was one question here from a member of the audience in regards to what 90-90-90 actually means, and I can explain it in simple terms. So the WHO, which is the World Health Organization, created a target actually 2 years ago to try to kind of help guide progress in regards to HIV care at a global level. And so the 390s the first 90 refers to that 90% of individuals living with HIV will be diagnosed, which means that, so there's a proportion of people that are living with HIV, and the goal by 2020 is to have 90% of all persons living with HIV in the whole world be aware and tested and diagnosed with their HIV infection. So that's the first 90. Okay. The second 90 is that 90% of individuals who are diagnosed and who are aware of their HIV positive status will be on antiretroviral therapy. So you take all the people that you know about, and at least 90% of people worldwide will be on antiretroviral therapy. And the last 90 is that individuals who are on antiretroviral therapy, 90% of those individuals or more will have achieved a fully suppressed HIV viral load, which is the end target. Okay, so I apologize for not making that more clear. Okay, are there any other questions from anyone in the audience?
Alex, can you hear me?
Yes, that's it. So thank you very much, and hopefully everybody will continue to participate in the various activities for AIDS Awareness Week this week, as well as Aboriginal AIDS Awareness Week the following week. Thank you.
Yes, it is.